Welcome to the NSCHBC Edge Podcast, leading the way in the business of medicine. Now here's your host, Terry Fletcher.
Hello, everyone, and welcome to the NSCHBC Edge Podcast. I'm your host, Terry Fletcher. The Edge Podcast is brought to you today by the National Society of Certified Healthcare Business Consultants. Our goal is to discuss healthy business principles, have conversations on the business side of medicine, so that you and your practice can be profitable and successful for years to come. This week on the Edge Podcast, I welcome Joe Lessard. Joe is a principal of Professional Business Management, a healthcare practice management consulting and accounting firm based in Barrington, Illinois. PBM's clients are private healthcare practice owners, and their number one goal since PBM opened in 1932 is to help them stay private. PBM takes a proactive approach with their clients throughout the year to provide deeper insights into their practice and to help them with the business side of things, focusing on their profit margins so that doctors can focus on their efforts on doing what they do best, which is patient care. Joe, welcome to the podcast.
Thanks for having me.
So we're really glad you're here today because I think that when we try to focus on the podcast on the business side of medicine, you had brought up a topic to me that I just think is really going to go over well to our listeners, and that's strategic choices, for medical and dental practices. And as you know, otherwise we wouldn't be in business, a lot of practices don't even know where to start. And so I'm going to just have you speak to a couple of things there and really kind of respond to what I'm also seeing out there. But let's start with this. So you had mentioned that you advise clients on what insurance payers to accept, so let's start with Medicare, Medicaid, and some of the commercial plans. How do you make that assessment?
Well, it certainly depends on your specialty, right? If you're medical, again, it's a different animal than dental. So I'll focus on medical for a second. Again, it really depends on your specialty. If you're internal medicine, you're gonna take everybody, or you're gonna take a lot of people, and you may choose to be in network or be a preferred provider. And again, you kind of have to stay up with your kind of competition, I suppose. But a lot of those choices are really made for you in many ways, unless you are moving more towards a concierge type route. But from a medical side of things, again, it really depends on your specialty, your area, what your competition's doing. But a lot of it's really made for you, unfortunately, unless you're trying to do something different, and that's more on the cash business side of things, like concierge.
Right. Now, so when you're saying that, does your company, do you actually do a deep dive into geographical location and exactly what maybe the patient population is? Because obviously heavier geriatric population maybe move towards more Medicare, and then if it's more of a younger crowd, then it would be probably more commercial, and then what the employers are in the area.
Yeah, we don't get involved on, what's your reimbursement rate for XYZ CPT code, and what your patient demographics are too much. Because we are focused on Chicagoland, and from most of it's very, very similar. Whether you are in Chicago or whether you're in Elgin and something like that, it's not going to vary too much geographically here.
It does definitely in other states.
It does.
Are you guys focused mostly in Illinois?
Yeah, we focus on Chicagoland area, Northwest Indiana, a little bit of Wisconsin, and again, for the most part, there's not too much. There aren't too many differences between the three.
Similar or the same Medicare payer, provider, Medicare administrative contractor. What's interesting is even though, and I guess you can speak to this, I'm in Southern California, and so we have different populations here, really down south, closer to San Diego, almost to the outskirts of the Mexican border. We actually have a very heavy populated Russian patient population. Then you move into maybe North Orange County, and we've got more of an Asian population. Then you go to, just different, we're Hispanic populations. And the reason I bring that up is that there are different payers also tied to some of the different ethnicities, some of the different patient populations. Obviously, socioeconomic status makes a difference, what insurance people can afford. Do you get into discussions in your geographic location as far as Medicare, or I'm sorry, Medicaid? We call it Medi-Cal here, so I almost said that.
Yeah, yeah, right. No, I guess it depends on, what kind of provider you want to be.
The reason I ask is only because a lot of providers want to shy away from it because it's not the best paying payer. But
Absolutely.
again, like you said, what kind of provider do you want to be? And if you're tied to a hospital, sometimes you don't have an option.
Right. No, you don't.
You're like,
And,
you're
and
telling
yeah,
me.
I think right. And I've talked to my clients, and as they're looking to start up, and where do you want to, again, what kind of provider do you want to be? Do you want to help the underserved community? And kudos to you. Your model is different than focusing on more an affluent area.
Right.
And your insurance choices and your in-network choices are vastly different. And your work life is vastly different. But your potential reward, one way or the other, is different. You
So
know,
you brought up an interesting thing just now about your life choices are different based on how you want to practice. I get a lot of clients that it's almost like you heard the phrase, as seen on TV. And so, and people sometimes see something and it's shiny and pretty, and then they get the realities of what it really is. And, I have a lot of clients or a lot of potential clients that come to me and say, well, I want to open up an urgent care, or I want to open up an ASC or a walk-in clinic. And sometimes I don't think that the due diligence is done on what that really entails, hours and staffing, and how do you have that conversation to guide them versus, let's say a traditional primary care practice. I hate to say those are 9 to 5, but technically, I mean, they kind of are.
yeah, they're supposed to be 9 to 5.
They're supposed to be, exactly.
I don't. Any of my primary care doctors are working well more than that.
Yeah.
Seeing patients probably 9 to 5, but again, it just my focus with our focus with our clients is really helping them provide the best ease of practice for what they want. And I have clients who want to make a lot of money, and I have clients who are comfortable and they like a better work-life balance. And I have clients that want to serve certain communities and ones want to serve different types of communities. And helping them understand, I guess, formalize what they want and then how to go about it. I work with a lot of dentists as well. And I work with a lot of startup dentists lately, and it's vastly different depending on the area. And back to your first question about insurance, again, that's one where we are really helping with more strategic choices on insurance and being in network or not, and when you're willing to take, because at some point you will, maybe at first with any healthcare practice, medical or dental, you are signing up for a lot of insurance, being in network, I should say. But at some point, mainly with dental, you are making those strategic choices to move away and go more fee for service. Because if you've built up enough reputation, you've built up a patient base where you can um, um, collect more for the services you're doing, and chances are, because you've built up a great reputation, you're going to lose some patients, but you're not going to lose as many as you think.
Well, and now, and with the No Surprise Act and how the handcuffs they put on you with that, it definitely behooves physicians just to look at the big picture, I would assume. So.
Yeah, it absolutely does.
So, question, one thing I noticed on your website, and I thought this was an interesting point of talking point, was the assistance you give your clients when it comes to hiring new associates or partners or thing in that nature. The reason I say that is because I got two different kinds of physicians, and there doesn't seem to be a in between. It's either they want to hire start with a practice of 10 doctors, 20 staff members, and let's just have go at it. And then there's other doctors or other providers that are like, well, it's going to be me, it's going to be my wife is going to handle the front, or my partner, or my husband if it's a female doctor, obviously. Don't want to discriminate. And or it's going to be, my sister-in-law's brother's cousin is going to be at the front desk. And I don't see the in between where, instead of saving money versus blowing the whole, 9 yards right away. How do you meet them in the middle and say, here's what you need now, and then how you build?
Advising clients on when to hire another provider is, I view it as something simpler than it typically is, and it's about access. And it depends on what you want to achieve. I have a dental practice, and they are hiring a bunch of general dentists, and they don't have the schedule to fill everyone's schedule. They don't have the number of patients to fill everyone's schedule.
Yeah.
They're making a strategic choice to say, hey, let's staff up now because hiring all these people, they're getting paid a certain percentage of their collection. So it's no harm, no foul from a cost structure, right? Because you bring in $100, you get paid a certain percentage of that, and that's it. And so it's no, from a financials perspective, it makes sense. You hire up, hire as many as you can, and so you can see, make some strategic marketing choices to target patients to bring more in and grow fast. And now you have the ability to serve those patients. That's a strategic choice. But on the other end, it depends also on control, right? Because again, some clients and most of our physicians, most of our dentists, they're going into private healthcare because they want control. They want to do things their way. And working with another colleague tends to limit their control, and they don't have as many choices, and they have to now collaborate with somebody else in how the business is run. Potentially, if it's kind of merging more towards a partnership, and that's a marriage, and you have to make sure you can work with that person. And so again, admitting another provider, again, I think is more of a strategic choice about what your goals are. Are you trying to make sure you can have the ability to see a bunch of patients? Once my solo doctors are in practice, typically they're not looking to bring on an associate until their own schedule is full, right? Because again, if you just hire someone to hire them, again, you are either making a choice to push forward on marketing to hopefully bring in more patients. But a lot of my clients are timid in many ways on that because, well, what's the point of me bringing in another doctor who is here and he or she is there all day and not seeing a single patient because we don't have the patient flow yet. And so usually that decision to when to hire somebody else is because I'm 6 months out booked. I can't. And depending on the specialty, that might be appropriate. Usually 6 months is crazy, but it again depends by specialty. But if you are booked out too far in advance, then you will lose new patients. You won't be able to get new patients because they will find somebody else. Might not be as good, right? But they will find somewhere else to go. And that's ultimately the decision choice.
Right. It's a decision. Or are you hiring somebody so that they can help build a practice and bring people in, or are you hiring them so that they can now take your overflow and build from there?
Yeah.
So yeah, no, that's always a good starting point with that discussion. It's interesting though because I do see so many providers. I don't know. I don't know if they think it's more credible not to be just one, and sometimes being your own provider plus maybe hiring some extenders can be helpful versus filling it up with, like you said, having but partners that may or may not be seeing patients throughout the day.
And there's another strategic choice in it too. Can that other provider do something different than what you do? And now you, as a practice, you can now offer a much more wide range of services
Right.
because maybe that associate is only there very part-time, 1 day a week or something like that. But now they can focus on doing something that you don't do, that you would normally refer out somewhere else. But if you can keep that in-house, that generally is an easy choice.
Right. I have a primary care doctor who was a solo provider for 28 years, but he started to see a lot of behavioral health and mental health issues that he said he was not equipped to do. So he would outsource And then I said, you might want to look into maybe a nurse practitioner if you're considering, cost issue or whatever, if you don't want to hire another doctor. He's like, nurse practitioners and PAs do that? I'm like, yeah. And so he found one that actually had, education and certification in that, and his business is crazy booming. So he actually had
Yeah.
to take on two of them because that is a really big niche right now,
Yeah.
dealing with behavioral health. So moving on to a couple of other things. Now, when you talk to them about new locations, I know that's a scary thought to, have several locations, or even just something simple like, and I know I say simple only because I do a lot of specialty practices, but simple choices like, should I lease equipment or should I purchase it? When you're talking to them about that, is it more about, and this is going to sound weird because I am not in this, I'm staying in my lane of RCM, so I'm asking you because this is your lane. Is it more about, the the inflation? Is it more about, I hate to bring up the word tariffs. Is it more about what they need right now, versus cost, or is it more about long term when, lease versus purchase, or is it because they found that, 30 miles away or 20 miles away. I don't know when you open up a new location, how many, what your geographic reach would be. But is it more because they, notice that they don't have patients in that area, or they've been told that they need something there? How do they make that choice to open a new location?
Usually they are entertaining opening up a new location, and it's to expand their reach. And when they do expand their reach, it's usually because they are either have the ability to overstaff, right? Because now that the practice that they have been running and being, and not only as an owner but being a doctor in that location, they now have to limit their ability there, right? Because if they're going to be taking the strategic choice of starting somewhere else, chances are it's them running that show, more, mostly, right? Because the patients are coming there because of usually the main doctor, right? And so you need to be able to entice. You can't just input, take a random physician, a random dentist in that new location. It doesn't work because you're not going to have the same draw. Now, once you get into, multi locations, your business model is vastly different. But if you're going from one to two locations, it's probably the biggest hurdle versus two to three and three to four, because now you are spreading yourself a lot thinner. And you now have to be sure your home base is stable, and you need to make sure you have an associate or somebody else, another partner who can do it like you do there. So when your efforts are focused on going somewhere else, you can replicate that because you need to. And usually you are going to another location to expand your reach into different areas, whether it's to continue that same business model into another area to expand your reach, or potentially it's even a different business model. We talked earlier about, types of patients. Are you going to offer a different type of practice where you're serving an underserved community? You can do that too, right? You can have different business models for different areas, maybe even potentially under a different name. But again, that's usually the choice, is to really expand their reach. But usually you then are operating more as an owner than you are as a doctor at that point, because you are now focusing on the operations versus, the clinical side of things.
It's funny. It almost sounds like a consulting business like myself, or even like your business, where people want, and this is going to sound arrogant, it's not meant to be, but people want the person that they trust. They want us, or they want, who they're talking to. And so you do run a little bit of a risk opening up another location. Again, like you said, if you're not the one there, but, you're using your name, and the expectation of what you've built in your, practice that you've started, and then now to expand it, it has to be consistent.
Well, what makes you so special
Right.
versus going to something that's potentially more convenient, right? The big kind of groups in our area are Dooley and Northwestern, and they're big, and they've got a bunch of, primary care all the way up to all the different specialists. But why would you, as a patient, want to see the private practice doctor or private practice dentist versus a health, a system, either run by some sort of private equity or some sort of hospital, right? Why would you do that? And typically, it's because of service.
Right. Service and what you said, access. Access is big.
Yeah, and if you start not having that same kind of level of service or access, then what's the difference? Then you'll go
Right.
to something that's potentially, you won't have that same touchy-feely kind of service, that friendly face. Now you'll go somewhere else that's different.
Yeah. Now, I want to kind of wrap up our discussion in this last kind of talking point here. And this is something that comes up in my, wheelhouse all the time, and that's outsourcing versus keeping things in-house. From accounting to billing to staffing, to I even seen some practices, which I don't know how this works. Is very odd to me, but I've seen practices do virtual management. I'm like, what? To me, you have to really be on site to do something like that. But that's just me. Maybe I'm old school. But those kinds of conversations. What are the doctors usually asking when that is something that comes up? Should I outsource this versus keep it in house? Now, I understand sometimes outsourcing is for lack of a better way, cheaper, but it doesn't necessarily mean it's better. So how do you deal with that? Or what is that conversation?
I guess it depends on what you are outsourcing,
Yeah.
right? And some will hire a management company to help run the practice, but again, if you're not there, how are you running the
How are
practice?
you running it? Right, right.
And that's why as a firm, we focus on practice management, and a lot of people come to us because, we're a lot of us are accountants, right? And that's what accounting and tax. That's why people come to us initially. But what makes us different is we have boots on the ground. We are visiting our clients.
Are you
And so for
really? I don't
our
hear accountants doing that. That's awesome.
No, yeah, we meet with our clients as 9, 10 times a year.
You actually
And
walk in their office.
yeah,
That's
yeah.
impressive, Joe.
And it's what makes us different and
Yeah.
allows us to, I mean, don't get me wrong. Are we visiting our clients in their office 9, 10 times a year? No, but
No, but
we usually do a combination, usually about half in the office, half virtual, because
yeah,
I can do different things, in person versus virtual and vice versa.
right,
But we do that because I can see so much. I
right.
can see how a patient interacts at the front desk and how that person checks them in, how they're talking about whether they accept insurance or whether they're in network, because that's a how you phrase that answer can change whether you have lost a patient or not. How are you collecting it? Are you collecting at time of service, right? How are you presenting treatment plans? How are you rooming a patient? Right? We're able to see these things. We're able to see the different people in their office and how they interact with each other that you just can't. Whether it's us focusing on that when we do that, or whether it's your own hire some sort of management company, right? You have to have boots on the ground to really manage anything. And it's impossible.
Well, it's funny that you said that because I did an on-site for practice that was getting really bad Yelp reviews. And they're just like, we just don't know what it is. And the Yelp reviews were very, just, they weren't clear. You couldn't figure out why they just didn't like it. They kind of focused a little bit on staff, but, the staff was always nice to the doctors, so they don't necessarily see it. So I just walked in anonymously one day and just sat in the waiting room. First of all, the chairs were so uncomfortable. And then I saw it was an orthopedic practice. I saw a patient in crutches walk up to the front desk. Just reminds me of because how you were talking about, the intake. And they walked to the front desk with their crutches and they had like a plastic bag in their hand trying to navigate that. And somebody was over the over the counter of the front desk tried to hand them a clipboard, then to go sit down and try to figure out how to do that. And the person just couldn't do it and they dropped the clipboard, but the person at the front desk just sat there and didn't help the
Oh
patient.
man.
Yeah, so I commented on that and I got up and helped the patient and hand them over and sit them down and they just looked at me and didn't because they didn't know who I was. And so, sat them down. I talked to the doctors about that and I said, we're going to have our meeting in the waiting room. They're like, well, there's patients out there. I go, well, as soon as they're done, I'm going to let you know what's going on out here. And they had no idea. And it was, and the complaint stopped as soon as that was fixed. But just in saying that, it is interesting because whether you do it one time, 10 times, even if once in 2 years, just to be able to see and visualize the climate in the office gives you a perspective of what's
It
going
really
on.
does. And there's other areas where people, outsource or potential outsource, right? Billing is probably the main
The
thing where
biggest one,
people
yeah.
think about outsourcing. I certainly encourage, well, it just depends. It depends on the personalities of the office and depends on the staffing, right?
Right.
And I think that really ultimately is the driving factor of whether you want to, or whether you need to outsource something. If you don't have the right people in your office to handle something, then yeah, you need to outsource. But those people, just because you outsource something doesn't mean you set it and forget it and they're going to take care of it. No, there's things that you have to put in place to monitor and track, and usually there's follow-ups with that. Whether that's in billing or whether that's patient forms and you're collecting that's the patient onboarding. There's accounting, right? Office managing or HR, right? There's a lot of different pieces that you can outsource, but you still need to have someone that's capable and willing to monitor all that.
You do. And I think, and we'll kind of end on this note and your comment to it. I think people also need to, when I say people, I mean, practice managers and providers, physicians, and to our listeners, remember bookkeeping and accounting are two different things.
Yes.
So, one's inputting, one is understanding the big picture. And Joe, you said that you're also tax planners. I think that, and you can quickly respond to this. You probably have seen a bookkeeping office versus somebody who actually has accounting knowledge.
Well, yeah, absolutely. If you're just bookkeeping is the best way I can describe that. And I'm not dismissing bookkeeping at all because it's needed. Whether the office manager is doing it in the office, whether it's the doctor is doing it, I try to encourage the doctor not to do it. When they're starting off, I encourage the doctor to do it so they know kind of the basics and know money coming in and coming out. But it's different because it's a check register. Bookkeeping is a check register, and we've all maybe not so much anymore. People they don't know, they don't even know how to balance a checkbook, but that's what that's what bookkeeping is. You are recording that item that you're spending money on, and you're categorizing it as you're putting a memo on it as to what you spent money for. But then the accounting is taking that a step further and producing kind of the bigger kind of the financial statement. But even beyond that, it's taking that further on a consulting perspective. And so what? What does a financial statement look like? What business choices am I going to make based on this financial statement? And okay, well, your revenue is this, but your overhead's this, and a lot of your overhead is really fixed in nature. So don't be focusing so much on your cost, your overhead dollars, but your top line number. And again, it's helping you understand that on a bigger picture that is often missing with my medical and dental practice owners.
I agree. Well, this has been just such an enlightening conversation. I truly appreciate you being here. So we'd like to thank Joe Lessard for being on the podcast today. We appreciate, again, your insights into this important topic in the business of medicine. So thank you again, Joe.
Thanks for having me.
You can find the contact information for Joe at nschbc.org under Find the Consultant tab. Type in Joe's first name, and there he is. As a reminder, the nschbc.org website offers monthly free webinars on a variety of topics, as well as a quarterly Medicare webinar update. For all educational offerings, go to the nschbc.org and click on Upcoming Education tab. That's it from me today, folks. Please join us again next month when we once again bring you the current and important topics in the business of medicine. Everyone, make it a great day, a great rest of your month, and thank you for listening to the NSCHBC award-winning podcast. My name is Terry Fletcher.
Thank you for listening to the NSCHBC Edge Podcast. Join us on the second Tuesday of each month as our consultants tackle the complexities of navigating the business of medicine. You can reach us on the web at nschbc.org, the National Society of Certified Healthcare Business Consultants.